Well, thank you very much. I'm really honored to have been invited to the World Neurosciences Summit to talk about the Curing Coma campaign. My name is Claude Hemphill, and I'm a neurologist and neurointensivist at the University of California, San Francisco, and I bring you greetings from the Neurocritical Care Society and our Curing Coma campaign. This is going to be a little bit of a different type of talk because I can't improve on the talk that went before. I think it's hopefully going to be complementary in terms of some of the scientific approaches that we're taking because of some of the challenges in terms of coma recovery. But I like to start with a case just because that always anchors us in terms of what we're thinking about and the patients that we are treating. This is a 53-year-old man, and he was found after a probable assault, and his Glasgow Coma Scale score is 6, where he's got decorticate or flexor posturing, and his pupils are bilaterally reactive. And this is at least one slice from his CT scan, which shows some hemorrhage in the subarachnoid, but doesn't show a large surgically evacuable lesion. And his family arrives at the hospital and asks to speak with the doctor. And what are they going to ask? Well, you may first of all ask, why curing coma? What are we talking about when we say curing coma? And this really goes back to what are the questions that patients, or really most often their families, ask when they come to the ICU, when the patient is in the ICU with a coma or decreased level of consciousness. They ask, are they going to die? Are they going to wake up and be able to talk to us and understand us? And is there anything we can do to increase their chances of waking up and having good cognitive function? These are the things that they care about and they ask. And they matter to our patients, they matter to their families, and they matter to us. And this cuts across most diseases we treat in neurocritical care: stroke, traumatic brain injury, hypoxic ischemic brain injury, CNS infections, status epilepticus. So this is a common unifying theme that has previously largely been considered separately based on each individual disease. But it's so prevalent that when we looked at this as a Neurocritical Care Society and thought, is there a scientific theme that we should try to take on to move the needle in neurocritical care, this is what we came up with. So what do you mean by curing coma? Because you might just look at me and say, what are you talking about? Curing coma, that sounds like a fanciful term. Really what we're talking about is promoting recovery of consciousness through early intervention and long-term support. That's what we mean. And I realize that as a neurologist, I may be not being precise in my language from a Plum and Posner standpoint, but really when we're talking about the Curing Coma campaign, we're thinking about coma and disorders of consciousness across the spectrum and focusing on recovery. So how do we prognosticate recovery right now? How do we look at this? Well, what we do is we use phenotype. We use what a patient looks like at the time. What is their neurologic exam? Maybe some demographics. And what their scan looks like at the time, anatomic imaging. And actually, a lot of people have done some pretty fancy mathematical models to try to develop tools. And we have the ICH score for hemorrhage or the impact score for traumatic brain injury. And unfortunately, we're wrong a lot of the time. And one of the real big concerns in neurocritical care now across diseases is something we call the self-fulfilling prophecy. And this is the idea that we have a patient who doesn't look good, and we assume that their prognosis is poor when they actually have the capacity to recover. And we limit care based on a presumed poor prognosis, and of course, they pass away or they don't recover because we didn't deliver aggressive care. It becomes a self-fulfilling prophecy of our inaction. And this turns out to be common and verified across diseases, whether it's intracerebral hemorrhage or traumatic brain injury or cardiac arrest. And it's a very important problem, and in any grant we submit for any type of research study in the US, we actually are required to figure out and present how we're going to deal with this issue. And Chris, why aren't we better at this? Well, I think it's probably because we're currently assessing what the patient looks like now, rather than assessing the true underlying mechanism of coma and impaired consciousness and the capacity of the brain to recover. But that's really hard. But we have some really interesting, relatively new studies that are challenging our notion of what it means to evaluate patients like this and what their potential recovery is for. Now, this is not a new study, 14 years old, but a group took patients, 54 patients with a variety of different diseases who had impaired consciousness long-term after discharge from the hospital months out, and found that if they did task-based functional MRI and asked them to do certain things, their brain lit up. They had a response. They were conscious, even though they could not follow commands in terms of the clinical neurologic examination. Okay. Well, now there's a lot more coming out about this. 5 years ago, Jan Clausen at Columbia University did this using EEG. Now, this is not regular EEG. This is sort of a fancy quantitative EEG using machine learning, but looked at 100 patients, once again with a variety of diseases, in the intensive care unit, and found that 15%, so basically 1 out of 7, had brain activation on the EEG, even though they couldn't follow clinical commands. And that's called CMD now. It's called cognitive motor dissociation. And if a patient had CMD, almost half of them had recovery to some type of independent function, where they were able to have self-care at least. Whereas if they didn't, much fewer recovered. So it turned out that this is some level of preserved consciousness early on that matters, even though we can't detect it on our clinical exam. And this paper came out just last week. Multi-center study, 6 centers, where they looked at patients in the early setting and some of them in a delayed fashion, and did imaging using these fancy functional MRI and EEG. But they found that of the patients that couldn't follow commands, 1 out of 4 of them had consciousness on their EEG. Now, they weren't necessarily wide awake, but they were conscious when we assumed they weren't. So I now assume that when I see a patient in the ICU and they can't follow commands for me, 1 out of 4 of them is probably following commands in their mind. And that, to me, is really important in thinking about this. So what is the Curing Coma campaign? Well, the Curing Coma campaign is a program developed by the Neurocritical Care Society, kicked off 5 years ago, to really enable 2 interrelated goals: to focus the science of coma and disordered consciousness on identifying and testing therapeutic interventions. We want to figure out how to bring therapy to patients, but also to form an enduring community of providers, scientists, and advocates to test and implement these advances. And we say there's a role for everyone in the Curing Coma campaign. If you are a cognitive neuroscientist doing this advanced work, there's a role in the Curing Coma campaign. If you're a nurse at the bedside who takes care of these patients and wants to help them do the best they can, regardless of how they may recover, you've got a role in the Curing Coma campaign. And this is just an organizational chart that shows all these different parts of technical working groups for science and community and World Coma Day. I'll tell you about that in a little bit. And right now there's over 260 active collaborators from various aspects. We have collaborators in India I'll mention shortly. About half of them are from outside the Neurocritical Care Society. And I want to tell you a little bit about some of the direction we're taking. And one of the first thoughts from our Scientific Advisory Council was to say, let's develop some scientific pillars. And so we're going to come back to this frequently in all of our Curing Coma campaign work. Endotyping, biomarkers, and proof of concept clinical trials. What's endotyping? Well, if phenotyping is what a patient looks like, endotyping is why they look that way, what their underlying brain networks may be in order to allow this to occur. Because different disease entities may actually result in similar clinical phenotypes. So open question here, open question. If a patient has a Glasgow Coma scale of 6 with impaired corneal reflexes, does it matter more that it was a ischemic stroke versus a traumatic brain injury, or is there something common about their consciousness and their network, and that's a disease we should tackle? That's something we're trying to sort out. Biomarkers are tools to assess this. And what we're really realizing now is some biomarkers are fancy and expensive and rare. I can't do a functional MRI, task-based functional MRI on my patients right now at my hospital. Some researchers can. But we've got molecular biomarkers that are being developed, and novel clinical neurologic examinations like the Coma Recovery Scale Revised Fast that I'll show you. And so across the spectrum of ways we can assess patients that are going to be important for biomarkers to assess brain network integrity and capacity to recover. So here's an example from Brian Edlow, who's a neurologist at Mass General. This is a patient on the left. It's a healthy control showing their diffusion tensor tractography on MRI scan. And on the right, it's a young man who is minimally conscious on day 7 after severe traumatic brain injury. And his network is not as robust, but it's still intact. And he's functionally independent at 6 months. So that's a patient who has the capacity to recover, but you don't know it on day 7. And if we could harness that, we may be able to implement treatments. Because really, clinical trials for intervention are what we need. Prognostication is something we have now, but our goal is to really improve recovery through targeted interventions. We do have a mantidine, which has been assessed in traumatic brain injury patients as sort of a proof of principle that may accelerate recovery. And this STIMPACT trial, Dr. Edlow is doing this, trying to take fMRI connectome positive patients and give them methylphenidate to see. So we set out this 10-year scientific roadmap. It's all very ambitious, and we recognize that, but this is how we change things. This is how we move things forward. But we're moving along, and there are a number of efforts that we've done, but there's a lot we've still got to do. So the first thing we did, and I just mentioned this to you because all of this is accessible. If you go to the Curing Coma website, you just type Curing Coma in your web browser and it'll pop up curingcoma.org, and you can get links to these articles or gap analyses on gaps in understanding classification, mechanism, trajectory of recovery, and therapies, and a novel approach to assessment called the ACCESS method has been proposed. But we really got to start somewhat basic, and that's fine. So one of the first things we did was something called Come Together, and it was an international survey of providers on coma epidemiology. How do you define coma? We know what the strict definition is, but how do you define coma? What tools do you have available, and what types of patients are you seeing with this? And what we see down here is the most common etiologies down on the right. Most common etiologies here are intracerebral hemorrhage, traumatic brain injury, subarachnoid hemorrhage in these places. But there's been some great work, and a group of collaborators did this, but did Come Together India. Because they said, there may be special issues in the Indian subcontinent and in South Asia, and we want to understand this better. And it was really, I thought, a great paper because, first of all, on the left are modalities that are available for folks to use. And I recognize that down here we've got, depth EEG and functional MRI, and they're not much. But everybody's got a neuro exam. Most places have CT scans. Most places have EEGs. So it's important to understand that in terms of gaps that may be brought forward, but also leveraging what is available and what you have. And this is a great diagram here that the group sort of said, what are the unique aspects of India versus the world in terms of the Curing Coma campaign? And some of it has to do with management, some of it has to do with etiologies. Traumatic brain injury is a big problem. And then a follow-up paper on the concerns in the India subcontinent. If we're going to say endotyping biomarkers, proof of concept, clinical trials are important, are there gaps there that are going to be important? Sure, there may be a lack of facilities to perform advanced testing, but rather than just saying, oh, well, can't do it, these authors said, okay, what's the way forward? Because we know this matters to our patients for the future. So developing centralized database to study endotypes and associated phenotypes. Biomarkers, limited availability of advanced imaging, like MRI perhaps, especially task-based functional MRI, focused on expanding available tools. Proof of concept clinical trials. Think about optimal trial design, integrating palliative care practices. And this is the way we come together and think about how to solve this problem on a global scale. So COMPOSE is a prospective observational study that's ongoing now of patient-level study of coma etiology and an outcome. And it's currently enrolling. I know that AIMS is a site and has enrolled a number of patients, AIMS here in New Delhi. And so that's been great to have that collaboration. And so the question is, a proposed idea of curing coma with limited resources. And I think the thing that's important to realize is, what do you mean by limited resources? We may mean limited resources in low and middle income countries, but a lot of places in the US aren't going to have some of these advanced tools. So how are we going to think about this? So here's a potential path of implementing technology as it becomes available, but education of providers on prognostic uncertainty and that covert consciousness exists. Embrace and utilize what you have. That was a fantastic talk, as I said before, and that is a roadmap to absolutely embracing what we have now as an expectation of being able to be good at that, And then other diagnostic tools, consider stimulant use, and then educating and counseling families on what I say is the possible, the probable, and the resources needed to get there, because this is challenging, and not everyone is going to be, or even should be, or wants to be supported long-term. These are challenging decisions, but it's important to address them honestly and openly. So I mentioned about the neuroexam. So the coma recovery scale, it's been studied and found that about 30% of patients who are deemed unconscious on the regular routine neurologic examination actually have some retained consciousness when the gold standard clinical test called the Coma Recovery Scale Revised is done. But that takes like 45 minutes. It takes special training. So the CRSR FAST has been developed as a way to assess this. It takes about less than 10 minutes to do. And if you want to learn how to do it, there's the case report form. But there's a link to the World Coma Day 2024 YouTube video on this is how we do it. And this is accessible anywhere, anyone that can do an exam and do it. Common data elements are something that we really felt like was a priority to develop, because these are content standards for research in domains, whether it's clinical exam or imaging or electrophysiology or outcome. They're basically ways to collect things in a standardized way. And so these have been developed. You can download the case report forms or look at the peer-reviewed publications for this. But the point is, when you develop your database that you need to do, that was identified by the Curing Coma group here, use the common data elements so we're all speaking the same language and we can harmonize that. That's important. And then I wanted to mention World Coma Day. We saw this as an opportunity to bring folks together. Scientists, clinicians, but also patients and families with regard to education. We were going to kick it off in 2021, and it was going to be something that we were going to do in-person activities, and then the pandemic happened. And we converted to Zoom, and that was ironically a blessing because it has improved our ability to collaborate in this context. We've picked it on March 22nd, 2023. It's the first day of spring. And so it's perhaps awakening. And so we not only have, and this is a map down on the right-hand corner of the countries that had any representatives from World Coma on World Coma Day. We talk about shout-outs and stories of hope as opportunities for ICUs and patients and families to tell their story in a little brief video. And last year, we had a session during World Coma Day. You can see, a number of the folks you know locally, but also colleagues from Nepal and from Japan and the Philippines. And we had a webinar during World Coma Day, and this was written up in our Currents newsletter. But it was really exciting and a lot of fun, and an opportunity to link folks together. So I want to finish up by mentioning some of the plans that we have for this ongoing year, and that's to complete Compose, to initiate this quality registry, to launch the Coma Common Data Elements for broad use anywhere. Anybody can use them. We had World Coma Day. We know that we've got a need for increased funding in order to conduct these research studies. And so we've submitted NIH grants in the US, but also philanthropic outreach is important, and additional publications from our coma science working groups. So just to finish up, say, curing coma, what do we do now? Well, I think it's important, I say, curing coma is mostly about culture change, moving from pessimism and nihilism to awakening hope, which is the Curing Coma motto, in a realistic and responsible manner. We can make a difference. This is about moving forward. We do need to recognize prognostic uncertainty and do what the neurology ethicist James Burnett calls prognostic humility. And then recognizing the limits of the clinical neurologic examination and the need for additional ways to assess consciousness, whether it's imaging, electrophysiology, more advanced and precise neurologic examinations, which I think there's a lot of opportunity there. Speak to our patients and treat them humanely. They may be more aware than we realize. And then be part of local and global communities for advancing scientific understanding, educating all of us, including patients and families and providers, be part of patient registries to understand incidence and outcomes, and bringing practical treatments to patients. So we recognize that the Curing Coma campaign is a grand challenge to fundamentally advance the science of coma, disordered consciousness, recovery in neurocritical care patients, and implement new therapies. It's a broad multidisciplinary effort that was initiated by the Neurocritical Care Society, but really goes beyond that now. So I'm inviting all of you to become a Curing Coma collaborator. You can click on that, submit a story of hope. That's a QR code. You or your patients can submit that. And I hope to see you at World Coma Day 2025. Thank you very much for letting me be part of the session.